morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audience in different parts of the world. Welcome back yet to another episode of ACNS webinar. The speaker for the first session today of our webinar is our honored guest from the United States of America, Professor Giuseppe Lanzino. Professor Lanzino is the Joseph and Barbara Eshkin Professor of Surgery and Professor of Neurology, Surgery, and Radiology at the Mayo Clinic, Rochester, Minnesota. He specialized in the endovascular and surgical treatment of patients with cerebral vascular disorders, including brain aneurysm, brain and spine arteriovenous malformation, dura fistula, carotid stenosis, and Cavanus Malformation. He completed his neurosurgical training at the University of Virginia, Charlottesville, Virginia. In addition, he has completed a subspecialized training in the neuroendovascular surgery at the State University of the New York at Buffalo, cerebral vascular and skull-based surgery fellowship at the Barrow Neurological Institute at Phoenix. He has authored and co-authored more than 600 peer-reviewed publications, and he is the author of 4 textbooks. We are extremely honored to have him today at our webinar today, and he'll be talking about Cavanus Malformation of the brain and spinal cord. The speaker for the second session today is our own guest from China, Professor Ming-Chu Li. He is a consultant neurosurgeon at the Department of Neurosurgery, SAMI Clinical Neuroanatomy Research and Learning Center, Capital Medical University, Zhuangwu Hospital, China International Neurosciences Institute, China INI, Beijing. He was assigned to the post of the Director of SAMI Clinical Neuroanatomy Research and Learning Center. His clinical focus is in micro and endoscopic skull-based surgery and related anatomy research. He's a key member of the Professor Gi Chen team of pituitary tumor and neuroendocrinology program. Since 2015, Dr. Li has been serving as a Secretary General of the Chinese Board of Neurological Surgeons, which takes charge of Chinese neurosurgical residents training program. We are extremely thankful to him to accept our invitation to be our speaker at our webinar. And today he'll be talking about how to learn the surgical anatomy of the skull-based bone and dura. The chair for the first session today is our distinguished faculty from Japan, Professor Kazuhiro Hongo. Professor Hongo is a director of the Ina Center Hospital, Ina City, Nagano Prefecture, Japan. He was previously the chair of the Tsinsu University Hospital. He specialized in cerebral vascular and skull-based neurosurgery. He has authored and co-authored more than 200 referred articles and several book chapters. We are extremely thankful to Professor Hongo for accepting our invitation to chair the session of Professor Lanzino. The chair for the second session today is our distinguished faculty from Brazil, Professor Ferez Chadat Neto. Professor Neto is a professor and head of neurosurgery department, Federal University of Sao Paulo, Unifes, Brazil. He is also the head of the vascular neurosurgery sector of the Unifes, and he has had the micro neurosurgical anatomy laboratory at the Unifes, and he is responsible for specialization and improvement program in the vascular neurosurgery for neurosurgeons all over the world. Professor Ferez did his postdoc in microsurgery anatomy at the University of Florida under late Professor Albert Roton. After this, he joined the Institute of Neurological Sciences of Sao Paulo as a research fellow in vascular microneurosurgery under late Professor Evandro de Oliveira. Professor Chadat is the integral part of the Brazilian Society of Neurosurgery and also a full member of Brazilian Academy of Neurosurgery. He has his affiliation with the ACNS as well as CNS. He is also a noted author who have published several articles and dozens of book chapters. We are extremely thankful to him for accepting our invitation to chair the session of Professor Ming-Chu Li. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences on this online platform of ACNS webinar. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. And with that introduction, I will hand over this online podium to our first chair, Professor Kazuhiro Hongo. Professor Hongo.
Yes, thank you very much for the kind introduction. I'm Kazuhiro Hongo from Japan. Well, it's a great honor and a pleasure for me to be chair of this prestigious long-lasting webinar. And the first session today, I will chair on the brain and the spinal cord Cavanus Malformation. I think there are many issues to be discussed on this lesion, such as treat or not, or if we treat, what is the modality of the treatment and the timing of treatment. For surgery, what is the appropriate approaches and timing of the surgery and intraoperative monitoring and so forth. But today, as introduced, we have a great guest, Professor Lanzino. I'd like to have his lecture. Professor Lanzino, please have your lecture.
Thank you for the kind invitation and for allowing me to share some of my thoughts about Cavanus malformation. So we have had a long-standing history on and interest in Cavanus malformations and of the brain and spinal cord. And I thought that I would structure my presentation into two parts. The first part will have some epidemiological data based on some of our recent observations. And then in the second part, I will discuss some surgical considerations and we'll go through some cases. As we know, Cavanus malformations, they can be sporadic and familial. I like to stress the fact that in the sporadic form, high resolution MRI has shown that there is almost always an associated so-called developmental venous anomaly. There is no developmental venous anomaly instead in the familial or in what are called radiation-induced forms. And when we look at the natural history, it's very important because there are really few data based on prospective large modern series. And because of this, in 2015, we started a prospective registry. And this was up to last year in August. We had 328 consecutive patients, slightly majority of women. The majority were sporadic Cavanus malformation, about 21% were familial form. And importantly, the median follow-up, we sent, either we saw the patients back, or if we didn't see the patient back, we sent regularly a questionnaire every year. So we have a median follow-up of 4.3 years. And what we were able to show and confirm, you can see in green, are those patients that presented with hemorrhage. And as we know, once you present with hemorrhage, not only with Cavanus malformations, but also with other vascular lesions like aneurysms and arteriovenous malformations, then the risk of other hemorrhage is much higher than those patients you can see in blue who presented with the seizure without hemorrhage, and the ones in red that presented with incidental Cavanus malformation. Now, what we found is that if you look at the risk of rehemorrhage after a first hemorrhage, that risk actually in the first 5 years, it's higher than what had been suggested by previous studies. And it approaches about 50% at 5 years once you have had a first hemorrhage. What was also a little bit surprising to us is that we always felt that the patients with incidental Cavanus malformations have a very benign natural history, but you can see that if you follow these patients over time, then the risk of bleeding is probably a little bit higher than what we had originally thought. What's important though is that in this figure, what we're looking at the percentage of patients with a good functional outcome. And as we know, even though, as we saw in the previous graph, the risk of another bleed is fairly high, the majority of patients, you can see here, about 80%, they or higher, they still maintain a good level of functioning, or an acceptable level of functioning. This observation is very important in the sense that, yes, once you present with hemorrhage, the risk of another hemorrhage is fairly high. But as we know, with cavernous malformations, unlikely other vascular lesions, another bleed that does not always result in major disability. And after a bleed, many patients, they recover to a good degree of functioning. So this is something important to keep in mind when we give an indication for surgery. Now, a question that comes up very often is Cavanus malformations. As we say, about 50 to 60% are women. They usually are diagnosed in patients of childbearing age. And the question is, how risky is in a patient with the known Cavanus malformations to have pregnancy? So in our series, we had 4 patients who presented with hemorrhage during pregnancy, but those patients are not considered in this study. What we consider prospectively those patients who had the known Cavanus malformations that went on to have a child, and we had 37 such patients. And in these 37 patients with the known Cavanus malformations, we did not observe any episode of bleeding during pregnancy, which led us to conclude, and this is in line with some other observations in the literature, that we don't feel pregnancy in a patient with the known Cavanus malformation is contraindicated. Since 2015 or 2016, we have had available a 7 Tesla MRI for clinical use. And when we first got the MRI, I was really hopeful that the high power MRI would have been very helpful in better showing and defining the Cavanus malformation. And I was hoping that would have led to better understanding of these lesions. After a few years that we have used it now in many patients, I can only conclude that the 7 Tesla MRI really does not have that much, except that, as you can see here, the 7 Tesla MRI on hemosiderin sensitive sequences gives a much better definition of the developmental venous anomaly, which is invariably associated with sporadic Cavanus malformations. So overall, not a major advance in this field, but again, it's helpful because sometimes you have a patient with the bleed and you don't know if it's a Cavanus malformation or not. And these patients, the 7 Tesla MRI has been helpful, because if it's sporadic and it's a Cavanus malformation, you should be able to see an associated developmental venous anomaly. If it's sporadic and there is no associated, if it's a sporadic bleed, there is no associated developmental venous anomaly, then it's unlikely to be related to a Cavanus malformation. One more thing that I like to bring to the attention of the audience is that many of these patients are diagnosed with Cavanus malformations, and they have a history of heart problems, and they need to be on aspirin. Sometimes they have atrial fibrillation. They need to be on anticoagulation. And of course, there is a natural worry that in a patient with the intracranial lesion, with the risk of bleeding, being on antiplatelet therapy, aspirin, or anticoagulation could be dangerous. Well, several groups, including ours, we have actually observed that aspirin or any antithrombotic therapy might be somehow protective against future bleeds. And I think this is something that will be a focus of major research in the next few years, because it's one of those emerging paradoxes that definitely needs more attention. The hypothesis how antithrombotic therapy might be protective, at least in the sporadic form, it's related to the fact that it is possible bleeding from a Cavanus malformation is related to thrombosis or slowing or partial obstruction of the drainage pathways through the developmental venous anomaly, and therefore antiplatelet therapy or anticoagulation might be somehow protective because decreases the risk of thrombosis of the venous radicals draining the Cavanus malformation. So once we have diagnosed a Cavanus malformation and we have good data about the natural history, really one of the most difficult parts of the entire process is to decide what to do. And I would say that in modern era, there are 3 options. Conservative therapy, which further observation. As I said, that is often a reasonable option, even after a single bleed in some patients with lesions in highly eloquent areas, because we have seen how, despite multiple bleeds, the majority of patients might continue to have a good degree of functioning. And then we have surgery that is fairly well established, can be done safely in the majority of cases. And we have learned over the years that surgery can be done safely, even in areas that traditionally have been considered highly eloquent or at high risk, like the brainstem, the thalamus, or even the hypothalamus. And then there is the issue of radiosurgery. Will not go into too many details. I would say that radiosurgery was considered for a long time contraindicated in patients with Cavanus malformations because not effective. But there have been a few recent series which might have suggested that radiosurgery might have a role, especially for those Cavanus malformations that are considered not inoperable, but that are considered at very high risk for surgery. Now, I'd like to share a few surgical principles about what I've learned over the years and how I think when I see a patient with the Cavanus malformation. And I will use primarily the example of patients with Cavanus malformations in highly eloquent areas like the brainstem and the spinal cord, because truly those are the patients where the decision making it's more nuanced. So when to operate? Well, I think that based on natural history, radiology, patient characteristics, we can really tailor the approach to the characteristics of every single patient and provide individualized decisions. Again, here is this is from another graph from our study, prospective study, where we looked at patients with a non-brainstem lesion and patients with brainstem lesion and the risk of hemorrhage. And you can see how the risk of hemorrhage, especially in the first 5 years, it's much more in the patients with brainstem lesions, whether or not these patients have originally presented with hemorrhage. So the other thing I like to bring to your attention is that when we consider surgery for brainstem cavernous malformation, so we used to pay a lot of attention to identify that part of the lesion that comes closest to the ependymal or a surface. But the other thing, from a surgical point of view, I learned that it's equally important to identify an ideal trajectory, an ideal angle of view to improve visualization and facilitate resection of the most difficult portion of the lesion. The most difficult portion of the Cavanus malformation tends to be the original, what I call the active Cavanus malformation, that is often relatively hard in consistency compared to the residual part of the Cavanus malformations. And being the most established one, it's often attached to the surrounding parenchyma. So I do pay a lot of attention when I look at an MRI of a patient to try to identify what is the origin, especially in a patient that has had multiple hemorrhage. And there are these large cavities filled with blood. I try to identify where is the actual bulk of the cavernous malformation. And it's very helpful in this situation to look at the original film in a patient who has had multiple bleed. The other thing that I don't feel that we pay a lot of attention when we discuss about these lesions is that cavernous malformations, if we consider the brainstem, often they span different compartments. From the midbrain, they might extend down in the pons, or they might extend superiorly into the thalamus. So that's also something that I think it's very important to consider. And the other thing, of course, nowadays we have tractography and we can identify different tracts, but still I feel that patient symptoms and how they correlate to the location of the lesion in the anatomy of the brainstem, the patient symptoms and the progression of their symptoms gives us a lot of information that it's important to keep in mind when we decide how to approach a certain lesion. The other thing that I've learned is that when we consider brainstem cavernous malformations, there are different ways you can get to the lesion. And I've learned that even though each one of us, we tend to prefer and be comfortable with one approach over the other, it's very important to have really a true open-minded approach and consider in a single patient all the possible different alternatives. So then another important issue is the timing of surgery. We always get asked, well, how soon after a bleed do you operate? Well, I think that the problem in operating on a patient who has had a recent bleed, so in the acute phase, just a few days, a day or two after the presenting bleed, the main issue has to do with the fact that often in the very acute phase, and you see this on the FLAIR MRI, there is a surrounding edema. And all of us, we have experienced that when there is edema in the brainstem, the normal parenchyma around the Cavanus malformation is very soft, almost liquefied, and therefore it's much more prone to mechanical damage than in the case of a slightly more established hemorrhage. Now, the other thing is that though you have to be careful, because if you decide to operate and you wait too long, then you start having reactive gliosis. You have a very well-established hemosiderin ring around the lesion. And this often increases the periphery of the lesion, then becomes really stuck to the surrounding brainstem, and this might increase the risk of mechanical damage during surgery. I would say that there is not a magical rule. Of course, sometimes you have patients that after a single bleed, they keep deteriorating because of multiple repeated hemorrhages over a short period of time. So your hand is somehow forced. But I think that there is agreement that if you can wait a couple of 2 or 3 weeks after a presenting hemorrhage, that seems to be a reasonable balance between allowing for liquefaction of some acute blood and at the same time preventing the Cavanus malformation from becoming too established and tightly attached to the surrounding brainstem. Another important concept from a surgical point of view that we need to keep in mind is that the Cavanus malformation often displaces, pushes aside, rather than destroying the surrounding parenchyma. And that's something I've learned to appreciate more and more. We all, therefore, in a situation like this, you might be left with the impression that the Cavanus malformation, that there is no floor of the fourth ventricle. But after you remove this Cavanus malformation, then you realize that indeed there was quite a bit of normal parenchyma between the lesion and the floor of the fourth ventricle. And this is something that I think we have to keep in mind in our approaches. And over the years, I've learned to gain a lot of respect for the floor of the fourth ventricle. And whenever possible, I try to avoid going through that route, especially for this reason, is that the MRI can be quite deceiving and you can have more floor of the fourth ventricle that you might think based on the original picture. Now, The first time I heard this differentiation was done by Professor Konovalov, and I think this is something that has served me very well in my decision making, is that you can differentiate the Cavanus malformations of the brainstem into two types. One is what he called the hemorrhagic type, like this one. These are patients that often they get better after surgery, immediately after surgery, because there is some significant degree of mass effect. Most of the Cavanus malformation is formed by clot of different ages. And if you work through a tiny little window, we use the suction. In some of these cases, the pathologist actually might not find evidence of an actual Cavanus malformation, because most of the material that we send is just organized clot of different ages. So these are the ones where we usually have the best results, those Cavanus malformations in the brainstem, where there is a fairly large hemorrhagic component. The most difficult ones are the ones that are more established, where there is a hemosiderin ring adherent to the parenchyma. These Cavanus malformations often they grow not through large hemorrhages like the previous one, but they grow almost through proliferation of these microcaverns. The patient might have a new mild worsening. You do the MRI and there is yet another new little area of relatively acute hemorrhage that leads to the formation of another microcavern. These are the patients that are at high risk of postoperative worsening, because if you indeed want to remove the entire Cavanus malformation, then to separate the limits of the Cavanus malformation can be quite challenging. And this is especially true if you have if you are working through a narrow corridor, as we often do in these cases. This is in that patient, of course, the approach was not an issue, because just through a midline suboccipital craniectomy, you lift the tonsil and the bulk of the Cavanus malformation is there. So if you have a good visualization of these ones, of course, even these ones can be removed with acceptable risk, but not if you don't have a wide access to the lesion. Before concluding, I will show some clinical cases to summarize some of these principles. This is a patient with the thalamomesencephalic Cavanus malformation. As I said, Cavanus malformation of the brainstem, often they span different compartments. This is a patient who presented with Turner palsy, hemiparesis, and the Holmes tremor from involvement of the red nucleus. In this case, again, the approach to these lesions, there are different ways to get there. But if you look at the MRI, I think in this particular patient, the supracerebellar approach will lead through a paramedian or lateral perspective, will directly lead to that portion of the lesion that comes closest to the surface. And this can be combined with the tentorial incision, so the transtentorial extension from this approach will give you a better inferior to superior view that, as you can see in this graphic reconstruction, gives you a better view. And here again, as I mentioned before, the active part of the Cavanus malformation is probably the most medial part, but the resection will be aided by the large hemorrhagic component. We do use neuronavigation. It's not something that you need in these cases, especially if you can go by anatomical landmarks, but you can see here through a supracerebellar approach, you can see the fourth nerve. We are on the lateral aspect of the midbrain at the level of the lateral mesencephalic sulcus. Of course, when you have a bleed, there is no sulcus because the entire brainstem is bulging. But so in this case, when you get there and you see something like this, I think it's nice. And you can see, of course, the neuronavigation is flipped. But you can see that with neuronavigation, it gives you that it's nicer to have that real-time feedback that indeed you are about to make your brainstem incision in the correct spot where you like to be. And this is the post-op in this case. And you can see the small trajectory we went through, and look again how much normal parenchyma was there surrounding the Cavanus malformation. And here is the pre and the post. And in the coronal, it's really nice how you can see that how that approach really took you directly right to the lesion. So there was a mesencephalothalamic Cavanus malformation. This is a different situation. This is a Cavanus malformation that from the midbrain extends inferiorly into the pons. This is a young lady who was presented with progressive sensory symptoms and imbalance. And you can see that because of she has had multiple bleeds over the years. And you can see that the most established part of the Cavanus malformation is inferior in the pons. You can see the hemosiderin, the heavy hemosiderin ring. So again, this is something that I consider strongly in my surgical approach. Again, different ways you can get here. You can do it through a pre-sigmoid approach, and or you can go retrosigmoid. It's a little bit too low into the pons to go through a paramedian supracerebellar infratentorial approach. Again, here is the most medial portion of the Cavanus malformation that is the most established part, the part where I expect to have more difficulty in removing. Again, this is the liquefied part, but this is the actual Cavanus malformation, it's medial. So in this case, after all this consideration, I thought that if I can get access to the Cavanus malformation here, coming from a supratentorial approach, then I will have a preferential view to the most inferior and also a better trajectory to the lateral portion of the Cavanus malformation. Here is a video. Patient is lateral position, the side of the pathology down, and this is opening the interhemispheric fissure. And this is to show that even in a situation like this was a patient with a very heavy patient, so swollen brain. But you can see once you start draining CSF, that's cutting, going down, cutting to the tentorium. So tentorium is often highly vascularized. And then you have this beautiful superior to inferior view to the dorsal aspect of the midbrain, immediately inferior to the fourth nerve, and staying lateral enough so that you are nowhere close to the superior cerebellar peduncle. You enter the Cavanus malformation, you empty the liquefied portion, and now you can see I'm working against the most inferior, and I have an adequate view of the most medial portion of the lesion that is the most established one. And you can see using that hemosiderin stained parenchyma and working very patiently, try to separate those portions of the Cavanus malformations where the lesion is definitely much more established and harder to remove. And here is the pre and the post-operative, and this particular patient with a good outcome. This is another Cavanus malformation of the lower medulla. This is again a patient that presented first with nausea and vomiting, then start having progressive sensory symptoms, and eventually start having some weakness. And here is was on May 20. And you can see here was a bit of conundrum. This is a patient that is progressing. At this point, yes, there is some edema, but because of the bleed, the Cavanus malformation comes very close to the ependymal surface. So in this patient, I elected not to wait any longer because I wanted to be able to use this window of opportunity despite some edema, just because the Cavanus malformation now came very close to the surface. Now, as we'll know, and you can see there was some improvement of the edema. This is only after 6 days later, and that's when we did the surgery because I didn't want to wait any longer to prevent the Cavanus malformation from retracting more inside the parenchyma. Here is a posterior midline approach, opening a little bit the obex. This is the floor of the fourth ventricle, and then we did some electrophysiological mapping of the floor of the fourth ventricle to understand, make sure that we were away from some of the nuclei. And then here, as you know, always the Cavanus malformation is deeper than you would imagine from the MRI, but just with the very small incision immediately of the midline where the lesion came closest to the surface, they use, like debulking the liquid portion, and then carefully, and you can see here that the surrounding parenchyma, it's a little bit softer because this patient was operated fairly acutely, but because of that, the Cavanus malformation is not quite as stuck to the surrounding parenchyma. And after internal debulking, that came out nicely. And then I learned with the time, you take your time, you carefully explore the cavity, and there is often a thin fibrin connective tissue layer that you can carefully peel off, and this is the post-operative MRI with a good result. I have just one more case on a spinal cord Cavanus malformation. I don't know how are we doing with time. Otherwise, I can stop here. I think probably I've gone.
Oh, you can go ahead, please, Professor Lanzino.
Okay. So Cavanus malformations of the spinal cord, they are about not common. The thoracic cord is more commonly involved. It's not uncommon. These patients can have a slow progression of neurological signs and symptoms over many years, but sometimes can also present with sudden and devastating hemorrhage. One of the characteristics of this spinal cord Cavanus malformation is that, as you can see in this case, a 32-year-old with rapid progressive paraparesis, you can see the Cavanus malformation is here. But look, the hemorrhage has extended also for a fairly extensive, you can see better here, the hemorrhage in these patients, they tends to extend using through the spinal canal for a few levels above and below. And in the chronic phase, this can be reflected also by the extension of the hemosiderin ring. So in this patient, you can see the bleeding from the Cavanus malformation right here, but there is also extension of the hemorrhage as shown as hyperintensity on T1 on some of the levels above. What are the indications for surgery? Usually we do surgery, of course, for symptomatic lesions. We tend to be fairly aggressive. We operate after a single bleed, especially if the lesion comes close to the dorsal on the lateral surface. For those rare lesions that are purely anterior, then we might elect to observe even after a first bleed. This is a case of a patient with a C2 Cavanos Malformation, presented with neuropathic pain in the shoulder. She did not have any focal deficit, and you can see here the Cavanus malformation. The beauty of the spinal cord Cavanus malformation is that in the majority of cases, when they come to the dorsal or lateral surface, you can really get a full exposure of the full length of the lesion. Here you can see the hemosiderin ring and stain that as often extends for several segments below the original lesion. So because this patient kept having a progressive pain, and that's probably was related to that progressive extension you can see of the hemosiderin, we elected to go ahead and intervene, and we do a laminectomy. I opened the dura separate from the arachnoid, and then here you can see the actual Cavanus malformation that comes to the surface. And this is like an intramedullary tumor. Once you have established the long axis of the lesion, it's very important to incise the pia a little bit above and a little bit below the actual portion of the Cavanus malformation, which comes to the surface, so that you don't manipulate too much the overlying parenchyma. And once they tend to be Cavanus malformations like a cauliflower. There are multiple portions that go inside the parenchyma. And once you carefully start going around, here is you can see is probably the DVA associated with that lesion. Then you carefully remove in a piecemeal fashion, and eventually you are left with this hemosiderin stained cavity. And then I spent a lot of time going around and removing, this small, tiny little connective tissue and tiny little vessels that are attached against the wall. And for the most part, and then I like to approximate the arachnoid to reduce the risk of teetering. Delayed teetering, it's really one of the major potential complications after spinal cord Cavanus malformation. So, and quick plug, we have a course that Dr. Parietal and their team are annual course that have organized, and you are all invited to Rochester. And again, thank you so much for the invitation and to allow me to share some of my thoughts and considerations about these fascinating lesions. Thank you again.
Well, thank you very much, Professor Lanzino, for the excellent lectures of the brain and some spinal cord cavernous malformations, overviewing, including the natural history and indication and timing, and showing some couple of very interesting cases. Well, first, I'd like to have any question from the audience panel. Well, okay, I have a couple questions first, then, okay, I hands on the other panelists to have raised questions. Well, one of my question is timing of surgery. You mentioned the couple of weeks after hemorrhage is the appropriate. I completely agree with you. For my series, about 4 to 5 weeks after the hemorrhage. But among your many cases, don't you have any case that you needed emergent surgery? You showed one medulla oblongata case that is not emergent, just 6 days after hemorrhage. Don't you have any case you needed to do emergency 1 or 2 days after surgery, after hemorrhage? Don't you have any?
Yes, I've had a few cases of where I had to do emergency surgery, and those were patients with rapidly expanding brainstem Cavanus malformations, where they start having breathing issues. So I've had a few of those cases. As I said, you know, that it's always a fine balance, but yes, there are those patients that present with one hemorrhage, and then after 2 days they have another worsening, and then so forth. And in those cases, your hand is forced.
Okay. Well, my second question is regarding the indication for surgery. You mentioned hemorrhagic and versus non-hemorrhagic. I think, of course, hemorrhagic is a good indication for surgery, but non-hemorrhagic, I think it's quite difficult to do surgery, as you mentioned. Any indication? Well, without any massive bleeding, no, without the apparent bleeding, like you showed the case, non-hemorrhagic case, not growing rapidly. So what is the rationale for doing surgery for those non-hemorrhagic cases?
Well, I mean, I think that the non-hemorrhagic, it's a little bit of misnomer. Those cases, they tend to grow because they bleed into small, very small caverns, and that's how the lesion slowly grows over the years. The indication for surgery, as I said, if you have in those situations, those lesions, you cannot, it's not possible to safely operate to a 2 millimeter opening in the brainstem. So if the lesion comes to the surface and you have an adequate corridor, then we would consider surgery. But as I said, those are the patients that quite often after surgery, they are worse than before surgery. So in those situations, I would look, and probably definitely try to avoid after a first symptomatic episode, because these patients often have very minor symptoms. But if they are young and they continue to deteriorate and the lesion slowly over time starts growing, I've learned that if you follow for many years, so if they are young and you can access the lesion, then we will consider.
Thank you. Yeah, I understand that for non-hemorrhagic case, you need to see long time for, and then decided to at the time of symptomatic, I guess. Thank you. Well, Well, any question from the other panelists?
Yeah,
Yes.
Professor Hongo.
Yeah. Oh, yes.
Yeah, I think the the best timing may be after the absorption of the hematoma, but another time is before the edema developed after the hemorrhage, and just actually within 3 to 4 days after hemorrhage. Sometimes when you resect this hematoma under the lesion, actually it can accelerate the recovery of the patient. Yeah.
Okay, thank you. So you do surgery around 3-4 days after hemorrhage.
Yes.
Well,
one timing is this.
Well,
I have a question for Lanzino.
Yeah.
Professor Lanzino, do you consider use some stereotactic radiosurgery like gamma knife or sub-knife for very deep and very functional location? And maybe the lesion is very small. But it's very deep location. If you do the surgery, actually maybe cause some neurological deficit. But if you use a small dosage of the like 1/3 of the dosage to treat the tumor, actually it can be decrease the hemorrhage rate about half and the 1/3 of the hemorrhage rate.
So for many years we would not have recommended or considered gamma knife, but recently I think some of the recent data are quite convincing. So I think that gamma knife does have a role. And in the situation you were describing, a small symptomatic, deeply cavernous malformation that is located in the middle of the pons, I would consider, because as you mentioned, now we have learned with the gamma knife with the low dose, and if you avoid targeting the hemosiderin ring, which you don't need to target, you can do it fairly safely. So yes, I would consider.
Okay, thank you very much.
I'm interested in the what my dear friend Professor Ferres is thinking, and what he doesn't agree. He has a lot of experience.
But I never indicated the radiosurgery. I have the same thinking of Dr. Oliveira. Some cases I can for diminish the rate of the bleeding, but I never indicated the radiosurgery for Cavernomas Malformation. It's a pleasure to be participating in this event. Lanzino is a great friend from Brazil. Dr. Evandro de Oliveira liked it a lot, Lanzino. Okay, Lanzino opened the United States for Dr. Evandro Mayo Clinic in Jacksonville. Thank you so much. So I have the same concepts of Lanzino in the indicator of the surgery. Okay, for me, I have two types of the treatment for Cavernomas Malformation: is conservative or surgery or microsurgery. Okay, I wait when the patient, the Cavernomas Malformation bleeding, I wait to solve the clots. To operate the patient. If the patient is bad, I operate in the same time. Okay, I operate in the acute phase. But if the patient is good, I wait to solve the part of the hematoma with Lanzino, and I need to identify the place of the Cavernomas Malformation. It's very important to me. It's very important for me, the location of the Cavernomas Malformation in relation with the hematoma. Why? Because most surgeons, mostly neurosurgeons, operate the cavernous malformation. Oh, I removed the clots, but they left the cavernous malformation. I have the same principles of Lanzino, and I have a similar case that his thalamus mesencephalic case. But I perform a surgery. I used the interhemispheric transcaloso transcoroid approach in that case. It's a subthalamic cavernous malformation. Why I use? Because it's located immediately posterior of the thalamic adhere. It's for me, it's a pleasure to participate here. Thank you.
Okay.
Professor Lanzino, last question for you. You mentioned the 7 Tesla MRI. Do you think it's helpful in making your surgical plan?
No, as I said, I had so much hope that the 7 Tesla, especially for Cavanus malformation, would have been helpful. But I don't see any major role for, except that you can see the DVA better. I also, I do tractography, but I don't use it that much because I go by location and by the symptoms of the patient. Based on the symptoms, you can tell which tracts are more involved or compressed. And so the 7 Tesla MRI has not been helpful in the surgical plan.
Okay, thank you.
Yeah, thank you very much, Professor Lanzino, for the great lecture. Thank you.
Thank you, Professor Lanzino and Professor Hongo. And we have a very nice session for the first lecture. And now I think we can go for the second session. May I call upon Professor Perez to introduce and to call upon our second speaker. Thank you, Professor.
Thank you again to participate in this event. It's a great honor to speak. I introduce me to Lee. I will comment about his that you show about the lab, how to learn the surgical anatomy of the skin-based bone and dura. Thank you so much. Go ahead, teach.
Thank you, Professor. Professors, thank you. Okay, it's a great honor for me to be invited by ACNS and Professor Xu Bin to give me this chance to introduce my experience to training the scalp-based bone and dura mater. When we're talking about the surgical approaches, there are 5 basic steps of basic procedures: the astrocranial, the bone work, and the dura, and the subarachnoid spaces, and the brain. For a young neurosurgeon, what he have to learn at the beginning of his career is to learn the bone, to learn the dura. And in the residency period, he have to learn how to make the craniotomy, how to open the dura. And there are many surgical techniques are related to the skull-based bone and the dura structure. So I think this part of the anatomy knowledge is very, very important for young generation of neurosurgeons, especially for the residents. My topic will focus on 3 parts. The first one is I will introduce my experience, my understanding of the landmark networks of the skull-based bone. There are 2 groups. The first group is along the margin of the skull base, and it's also the margin of the convex of the skull. And the second group is landmarks are on the inner surface of the skull base. And the second part is I'll explain my philosophy of analyze the skull base bony structures. I will give an example of the anterior clinoid process and the adjacent dural structures. Finally, I will talk about the training in the lab. On the lateral margin of the skull base, there are there are some important landmarks located on the convex, on the margin of the convex. If we observe a skull, we can see these 4 points are critical landmarks for the anterior skull base. This one is nasine, the supraorbital notch or supraorbital canal. This is the anterior end of the superior temporal line, and this point is Tyrian. All these 4 points are located at the margin of the anterior skull base. And we observe the skull from lateral. We can see the Tyrian, the point of just posterior to the junction of the sutures, the 3 sutures, the frontal, sphenoid, and zygomatic bone. This point is actually this point is the midpoint of the McCarthy keyhole. And here, the lower point is located at the corner of the at the turning point of the infratemporal crest. And this point is just medial to the anterior end of the zygomatic superior ridge, superior margin. And here, this point is located just at the anterior margin of the zygomatic arch. And we call this point is, you can see the point here also on the left picture. We call this curve as the posterior notch of the zygomatic arch. And here, this point is the porion, which is located at the uppermost of the external auditory meatus. And here, the last one of the temporal of the middle fossa is the we call it a parietal temporal point, which is just located at the anterior end of the parietal mastoid suture. And this point represents the lateral end of the petrous bone. On the posterior fossa, there are also 3 important points. And the first one is just posterior and inferior to the parietal temporal point and located at the corner of the transverse and sigmoid sinus. And the second one is located inferior to the first one, and is located at the corner of the vertical and horizontal segment of the sigmoid sinus. The last one located at the junction of the free edge of the foramen magnum and the posterior end of the condyle. So these 12 important landmarks delineate the lateral margin of the skull base. And by knowing this, we can precisely locate the bone window when we do a particular surgery. For example, if we want to do a frontolateral approach, we will use the point from the supraorbital notch to the Tyrian, and we can tailor the bone flap of the bone window on purpose, based on the location of the landmarks, based on the patient's condition. And we also have to know that besides these 12 red dots, there are also many landmarks on the lateral, on the anterior, on the posterior fossa. As a resident, you have to you have to know, have to very familiar with the distance and the orientations of different landmarks. This is very important. The more detail of the landmark network you know, the more confident you will be in the real surgery. The other landmarks are located in the inner surface of the skull base. Of course, on the outer surface of the skull base, there are also many landmarks. We don't have much time, so we'll discuss the landmarks in the inner surface. When we're talking about when we observe a skull, we usually divide the skull into two parts. The superior parts are the convex, and the other part is the skull base. If we observe the skull base part from above, we can see all the structures in the inner surface of the skull base, but not all the structures we can see are skull base structures. Here's the line that delineates by the 12 red dots. All these red dots are corresponding to the red dots we will observe the skull when we observe the skull from outside. For example, this one is from cecum, and this point is corresponding to the nasum. But between the 2 points, there are the frontal sinus, and the 2 points are have 1.5 maybe centimeters distance. But this point is the nasum's projection in the inner face of the inner surface of the skull base, and here is the projection of the supraorbital suture. Here is the anterior, and so on and so on. In fact, only the structures media to the blue line are the skull base structures. This part of the temporal acts as this part of the bone serves as the lateral wall of the temporal lobe, but it is not skull base structure, because when we do a subtemporal approach, we will remove it, and then we can reach the blue line. This is the real margin of the skull base. And in the posterior fossa, we also notice that this part, the squamous part of the occipital bone, are not skull base bones, because they are corresponding to the suboccipital surface of the cerebellum, and actually they are convex of the cerebellum. The real margin of the skull base is located between the 3 red points. And when we're doing some extent craniotomy, for example, when we do a mini orbital zygomatic approach, we usually cut more skull base bones. For example, this is the spinal ridge. This green dot is the lateral ends of the superior orbital fissure. When we cut the bone from the supraorbital fissure, supraorbital notch to the lateral end of the superior orbital fissure, then to the lateral end of the inferior orbital fissure, then we cut the superior and the posterior wall of the orbit, and then we push the skull base margin more medially, and then we shorten the distance from outside to the structures located more medially, located in the central skull base. Similarly, when we cut the bone or remove the bone, drill the bone from along the petrous ridge from the parietal temporal point to this point. This point is located just posterior to the arcuate eminence. When we cut the bone from the porion to this point, then to the posterior part of the jugular tubercle, then we can remove the lateral portion of the sphenoid, the lateral portion of the petrous ridge, and we can push the blue line, push the margin of the skull base to the yellow line, to more medially, and we can show the dura originally on the skull base, the subtemporal triangle dura and the Trotman and dura, and the Trotman triangle dura. So this is the basic knowledge for the standard craniotomy and extended craniotomy. Sorry. There is another line located in the skull base. This line just connect the dural entry point of the cranial nerves. For example, this is the olfactory nerve. This is the optic nerve, the oculomotor nerve, so and so on, to the caudocranial nerve, the hypoglossal nerve. These points are the points that the cranial nerves passing through the dural mater or cross or enter into the bony canal of the skull base. So there's another line just connecting all the cranial nerves. In skull base operation, we usually remove the bone along this orange line. For example, the anterior clinoid removal, the anterior petrous apex removal, so and so on. We will remove the bones along this orange line. This is critical because when we remove, after we have removed the bone or open the dura, then we can free the cranial nerves. This is the basic philosophy of skull base. So the bones, the deep bone drilling along this orange line or between the orange line and the yellow line are very important. We have to know the structures of this part. There are many landmarks located in the skull base. Otherwise, the 12 red dots and along the red and orange line. For example, this point is the anterior point of the optic canal. The orbital orifice of the optic canal. And here, this is foramen ovale, the anterior limit and posterior limit. Foramen rodentum. This is for foramen ovale, the anterior, posterior, so on and so on. And here, when we talk about the skull base structures, as a young neurosurgeon, we have to know the directions of each structures. There's an important reference line. It's the skull base cross. This is introduced by Professor Habishun, and I think this is very useful for orient the surgical direction when we're doing skull base surgeries. This is the tentorial ridge, and this dark blue area is the limits of the paracelic compartment of the cavernous sinus, and this is the region of the central skull base. The central skull base is located media to the lateral end of superior orbital fissure and media to the internal auditory meatus. This area is the most difficult area when we're doing skull base surgeries. This is the details of the anterior lateral approaches. For example, this portion, this green portion, is the superior, the roof of the superior fossa. It is defined by the green lines, green dots between the yellow and the orange lines. This is the roof of the superior orbital fissure, and here this is the roof of the orbital apex, the roof of optical canal, the anterior clinoid process and its basis, and so on. I don't have much time, so I will go through rapidly. So this is the lateral approaches. This is the coarse area. This is the area when we drilling the anterior part of the petrous apex. This part is located just beneath the macros cave, and here is the posterior face of the petrous bone. The superior wall, the superior aspect of the posterior wall of the internal auditory canal, the posterior aspect of this bone. And here is the glass-quark triangle, and here the superior wall of the jugular bulb. And here this triangle is located lateral to the foramen spinum, and this triangle connects the foramen spinum and the posterior notch of the zygomatic arch and the porion, the superior ridge, the superior edge of the external auditory canal. And this triangle is this area is the projection of the joint. And here, this is the roof of the external auditory canal, and this part is the origin part of the eustachian tube. And here is the superior aspect of the semicingulus. So I will go fast. So all these areas, on the skull base, there is no bone that we will not remove, we will not deal with in a particular neurosurgery, in a particular operation. So for a young neurosurgeon, we have to know every part of the skull base, and we have to know the triangles, so the networks of the different approaches based on the landmarks, based on the landmark networks. Next, I will talk about the construction of a bony structure. Because all the skull base structures are three-dimensional, and they have three-dimensional configurations, even the very tiny structures. For example, the lesser sphenoid ring, this is the anterior clinoid process. And here we can also observe the superior, the roof of the optical canal, the optical strut located here, tuberculum sala, carotid groove, so and so on. On this very small area, there are many structures, and all the structures have many faces, surfaces. So it's very difficult to understand. This is when we observe the anterior clinoid process from posterior. Here we can see the posterior aspect of the optical strut, and this is from superior to observe the anterior clinoid process and optical strut. We can see the posterior surface of the optical strut is continuous with the medial surface of the anterior clinoid process. So it's very difficult for a young neurosurgeon to analyze these tiny structures. How can we learn the knowledge, the three-dimensional knowledge? This is a very important question problem for your neurosurgeons. This is when we observe the optic strata and clinoid process from anterior. You can see the anterior ridge. Okay. Here, when we try to know the three-dimensional configurations, we have to notice the important points. For example, when we're talking about the optic strut, we have to identify the anterior ridge of the optic strut, the superior end of the anterior ridge, and the inferior end, so and so on. There are six important points, and between these 6 points, there are several important lines, and all the lines can show us the surfaces. For example, the 2A and 2B are the posterior surface of the optic strut. Its corresponding pictures is here. We can see the posterior surface of the optic strut. This is the upper ridge. This is the posterior ridge of the optic strut, and here this is anterior ridge of the optic strut. So the optic strut has a 2 attachment and 3 free faces. When we try to understand the anatomy of the lesser sphenoid wing, we have to notice all these points and lines and surfaces. This is the optic strut, the projection of the optic strut. This is the anterior, the tip of the anterior clinoid process. And here we can see how the anterior clinoid process is connected with the optic strut and the optic canal roof. And here we can see the, when we doing real operation, we will transect the anterior clinoid process along these 3 points. So here, this portion is the basis part of the anterior clinoid process. After we remove this part, we can see the attachment of this optic strut to the anterior clinoid process. So this is my philosophy to analyze the 3-dimensional structures of the skull bone, a skull base bone, not only for the anterior clinoid process, but also for the other parts of the skull base bones. Meanwhile, we have to analyze the surface structures of this area. For example, the anterior clinoid process this is the tip of the anterior clinoid process, and this is the anterior limit of the prechiasmatic groove, and here is the posterior edge of the optic canal roof, and these 3 structures are connected as a line. And the yellow line delineates the distal dural ring, and the green line delineates the proximal dural ring, because the distal and proximal dural rings are dural structures, and the proximal dural rings are part of the periosteal membrane, periosteal layer of the durometa. So we have to know the bony surface structure, the bony surface of the clinoid process. Then we can understand the distal and proximal dural rings. This is an enlarged photo. I will go fast. This is the transection of this is the section plane of the anterior clinoid process and the tuberculum sala. We can see this is tuberculum sala anterior clinoid process, and this is the outer layer of the durometa. And here the red lines indicate the the inner layer of the dura mater. And we can see the cranial nerves passing through the cavernous sinus. And then we can find that this is the inferior media aspect of the anterior clinoid process. On the surface of this part of ACP covers the periosteum layer of the dura mater. And here, just above the oculomotor nerve, there are also a layer of dura mater, the outer layer. And when we doing the surgery, when we drill out the anterior clinoid process, after the clinoid process has been removed, we will expose the outer layer of the dura mater, and then we can see the so-called carotid membrane and oculomotor membrane and the proximal dura ring. Here, this is the proximal dura ring, just as the turning line of the carotid and oculomotor membrane. Here, the distal dura ring is true dura ring. It's made of made by the inner layer, the red layer of the dura mater. Finally, we talk about the training in the lab, because when we, as a young neurosurgeon, when we learn the anatomy of the bone, the three-dimensional anatomy of the bone, the dura, is very, very difficult and very boring. So the training in the lab is absolutely necessary for young neurosurgeon. I think if one have a dry skull base, the first work for the learning of the dura and the bone is to observe the skull base very, very carefully under the microscope, and then try to drill the skull base. After you have previewed all the materials, all the books and the videos other people have done. This is a teaching material in our lab. We have removed all the parts of the skull base bone and preserved all the important landmarks. For example, here, this part is the lateral end of the trigeminal notch, and this is an important landmark to locate the carotid artery, to locate the cochlear, to locate the internal auditory canal. So we preserved this part and removed other part of the skull bone. And here the pictures from different observed aspects. Sorry, maybe I have no time. Another important method to learn the skull and the bone is to use the skull-based specimen without the brain. Then you can observe the dura mater and dissect the dura, to drill the skull-based bone very, very carefully and with a tiny drilling bit, and then gradually expose the dura and the skull-based bone structures, and then to show the important nerves and carotid arteries. Only on the skull-based specimen without the brain you can do this, because when if you do the same procedure in the skull-based trajectory, you will not find the secrets of the anatomy, because the observing trajectory is fixed. Only in this kind of specimen, the observed angle is free. The third important thing I want to say is we have to observe the same structure, not only in the endoscope, not only in the microscope, but also through the endoscope. Because for the skull-based surgery, the endoscope and microscope just like the left and right hand. So we have to observe the same structure through endoscope and microscope. For example, this is the anterior clinoid and the optic strut from the microscope and the endoscope. Imaging is very important. In the lab, when we learning the knowledge in the lab, we also pay a lot of time to observe the films, to know the structures on the MRI and CT scan. This is very important. Finally, I will give you a summary of this lecture. The landmark network and roadmap of the skull base is very important for young neurosurgeon. The second, the three construction of the skull base structures are very important, and we have to learn to how to reconstruct the skull base bone in your own brain. And the third, the training in the lab is absolutely necessary. We cannot, as a young neurosurgeon, we should not just be satisfied by knowing the name of the structures. We have to dissect the specimen, to observe, to describe it, and to record what you have seen. That's all. Thank you very much. Thank you for your attention. Thank you.
Very good presentation. Initially, Professor, my apologize for the way I introduced Professor Micheli. I didn't know that I needed to introduce you. Sorry. Your class was wonderful. Okay, I will incorporate your class in my class. I have a good experience for remove the anterior clinoid process, for example. But I use your class is very important for us because recognize the chronomeric points because they are our landmarks in surgery. We need to correlate these chronometric points to correlate these with the lateral and basal and medial surfaces of the brain. The knowledge of the anatomy of the skull base, the anatomy of the skull base is mandatory for us because we always work in the operation, the OR, with the vascular and vascular neural and the bony reference. As a neurosurgeon, we can access the pathology of the skull base with the microsurgical or endoscopic approach. It's depends of the ability of each neurosurgery. The neurosurgery has to access the lesion of the skull base with 3D film because the anatomy in the cerebrum is always in the 3 dimensions. How do you get to build these triangles bone reference in the skull base?
I'm sorry, beg your pardon, please.
How do you get to build these triangles bone references in the skull base?
This is a long-term experience because I have my mentor, Professor Bao, is a very famous skull-based neurosurgeon, and he have introduced many books for us, and we have learned the basic triangles of the skull base. And when we learning the skull base anatomy, we found that there are many obscure parts, especially the conjunction parts of different structures. So we have to specify the distance, the extent of the particular structure. So then we think about where is the joint point, where is the turning point. Then gradually we we find that the landmarks are very, very clear in the skull base. And when we connect the different landmarks, we can find there are many triangles, there are many other shaped the surfaces. And this is very important for us. And we repeat our observation on the cadaver head. And then we can gradually have the knowledge of triangles.
How many cadaveric specimens do you use for this information?
For the dry skull base anatomy, we have tried on 5 cadaver dry skull base, and for the skull base with dura, maybe 10 or more than 10, less than 20.
Yes, but I use, for example, the anterior clinoid process. For me, I had in my mind, for example, the anterior clinoid process is the middle extremity of the last sphenoid wing, is the lateral wall of the optic canal,
Yeah.
is the roof of the superior orbital fissure, is the anterior part of the cavernous sides. I correlate the bone with the optic nerve, is the part of the sylvian fissure, is the third nerve. Your class was very, very, very good. I will invite you to give a class in my lab this year.
Okay, thank you.
Any questions?
Yeah, may I ask one question, Professor? Thank you for a very nice lecture. I have 2 questions for you, Professor. One is how reliable is this cranial metric point in the pathological bone surface? That do we still rely on this point, or we now go towards a 3D model printing or IGS system to help us? My second question, Professor, how important is the knowledge about cranial metric point of endoscopic view, especially lateral skull base? Thank you, Professor.
The first question, what I just talked about is the normal anatomy. This is quite different. This is the basic knowledge for we know the pathological anatomy. Before we analyze patient's film or patient's 3D printed skull base, we have to have the knowledge of normal anatomy. So I have observed the landmarks on maybe 10 cadaver heads, so dry skull base, or the skull base specimen without brain. I think it's very reliable, and we do a lot of measurements for the normal anatomy. On the pathological condition, in the pathological condition, if there's a tumor, we usually see the retraction. We often see the diminish, the destroy of the bone structures, and the landmarks are less than the normal structure. But there must be some landmarks left in the patient. So in the pathological condition, is real operation for a neurosurgeon. You have to use all your anatomical knowledge to find the clues to localize the normal important structure. For example, the carotid artery, the third nerve, so on and so on. I think in particular for the skull base surgeons, anyone who wants to be a skull base surgeon should learn the skull base anatomy, not only by the microscope, but also in the endoscope, to observe one single landmark, to observe one structure. Nearly all the skull base approaches its final step is the central skull base. But for the endoscopic surgery, the first step is central skull base. So many structures that cannot easily be seen from traditional open surgery, but it's very easy to be observed, to be detected in the endoscope. So we have to learn through different angles for this. We have made a lot of three-dimensional anatomical videos for this purpose. Not only the 3D endoscope, but also for the 3D microscope to observe one structure from different angle. This is very useful, and you can short the learning curve for young neurosurgeon.
Thank you, Professor.
How do you stimulate your residents to go to the lab?
Oh, it's a good question. Yeah. Every year we have about 10 senior residents, we call it senior residents, to work in our lab. In normal years, not in the pandemic years, we will have about 70 to 80 young neurosurgeons come from over China to our laboratory to learn the surgical anatomy. About 40 of them will spend 6 months in the lab and to learn the endoscope and microscope anatomy of the skull, not only the skull base, but also the brain anatomy.
Yeah, thank you. I am okay.
Yeah, I have one more question. Professor. What's your opinion regarding the 3D simulation workshop? Now people using this 3D, how accurate is that is compared to the cadaveric workshop, Professor?
Yes, we have tried a lot of 3D reconstruction. We have used this in use the VR environment in 3D cameras to simulate the surgeries. It's very useful to understand surgery. Actually, there are some knowledge cannot be learned on the cadaver head. You have to learn it from the 3D construction of the imaging. For example, the fibers, the white metal fibers, or a tumor that's located in the foramen magnum, and then you can reconstruct all the structures around the tumor. This cannot be seen in the cadaver head, so you have to learn it from the 3D reconstruction. But this cannot displace the cannot be substitute of the cadaver head. You have to learn it in the cadaver head, because the fascias, the tiny nerves, the small vessels, and the feeding, the feeding of the dissection is very important. And the drilling, when you drill a bone, I have tried some kind of the simulator, the drilling simulator. It cannot be as good as the cadaver head, so you have to try it on the cadaver head. So in our institute, all the residents have to go to the lab, have to spend at least 3 months in the lab to study the anatomy. Thank you.
Thank you. Any questions? Shu, Professor Shu, do you have any questions?
No questions, because I'm very familiar for this content. Thank you.
Thank you, Professor.
Yeah. So tonight we have more than 1,600 in WeChat channel.
Thank you.
Quite a number. Yeah.
Thank you.
Congratulations for your class. Very wonderful class.
Mm-hmm.
Maybe we can hear the concluding remark from Professor Perez.
Thank you. The laboratory is the most important for students, for residents, for neurosurgeons, for master. to learn that how do you operate. The laboratory is mandatory for learning how do you learn the anatomy, to learn the techniques of the surgery. Is the best place to learn. Thank you so much. Thank you so much.
Thank you. Hope to see you.
Thank you.
Thank you, Professor. So I'm going to close this officially. And on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Professor Giuseppe Lanzino and Professor Ming Chu Lee, as well as our chair, Professor Kazuhiro Hongo and Professor Perez Chadat Neto, for the time and support for the ACNS webinar. I also would like to express our sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. And today, as what mentioned by Professor Zubin, we have 1,600 people who join us live. Hopefully, we will see again next week, Wednesday. And it is bye-bye from all of us. Thank you very much, Professor.